give him a warm welcome, even as he takes the stage to understanding turnaround time. David, would like you to take up the stage, even you
thank you, Nelly. And
present to us.
thank you, Nelly. I really appreciate that introduction that you have given. But as we are not men of so many titles, so we tend to really focus on analytical work and quality in the lab more than the titles. But it is amazing. It is another opportunity that we get this time to have a discussion. And our discussion today will actually be centered around turnaround time. So in essence, turnaround time is a simple concept to those of us who really understand what it brings on the table. It is a very simple aspect of the lab in its essence, but actually goes way beyond carrying the entire QMS on its back. That's why it's very important that we really have this discussion so that we understand why it's key. Just a bit as I navigate a challenge here. Colleagues, just bear with me. We understand system issues and I'm just getting it resolved.
So as Davies takes care and prepares to start, I'll just want to remind you that our webinar is that once you've registered via the link, and when registering, kindly use your ID number, correct ID number, registration number, and email address, the correct one. Once you submit, you'll get a link via your email that will help you to join into the webinar once the webinar starts. And that also, we remind you that we are KMLTTB accredited, and these webinars usually attracts 3 CPD points, which are participants here, are participants that participate up to 60% of the time you are eligible for the CPD points, and also certificates of participants are usually a personal email address. Again, we also, if you miss on this timing, you can have have learning going on the website. So let's check on Davis. Davis, if you're ready to take it off.
Nelly, can you get me?
Also, yes, I can get you, Davis. Are you okay now?
I don't know what the problem is. I'm having a problem moving my slides. Okay, I think we are sorted.
They're moving.
So,
They're moving. Yes.
okay, thank you. Colleagues, ladies and
You're
gentlemen,
welcome.
apologies for that hiccup. System issues, sometimes they come up when you least expect them. So we were saying that today's topic is about turnaround time. And turnaround time, it's in its own essence, is a very simple but very weighty subject that we usually have in our clinical testing areas. That's why I thought it's wise that we have this discussion today. So why is this discussion important for us today? Turnaround time has become of a central focus actually in our daily operations in the lab, because it reveals more clearly than any other indicator that you might have in the lab how effectively your systems are functioning. That is why in my introductory statements, I said turnaround time on its own can actually digest your QMS. It tells you how robust your QMS is and how subjective it is in its essence of service delivery. Of course, it is the point where workflow, discipline, staff coordination, and service expectations converge. It's a converging point. How well are your workflows? How well is your staff coordination? And how well are your service expectations aligned? Of course, those can actually be measured using turnaround time as a factor. So we go to a definition of turnaround time to get to understand what turnaround time is, and we'll be looking at generic definition of turnaround time. Then we will also look at a refined definition of turnaround time. Generic definition of turnaround time, what we are actually used to is turnaround time is the total time taken to complete a laboratory test process. Okay, and this evaluates from the moment a test request is received to the time the verified result is released to the clinician or the client. I repeat again, just for emphasis, a generic definition actually looks at the total time taken to complete a test, a laboratory test process, linking these two processes. The test request is received, the time from when the test request is received to the time a verified result is actually released to the patient or a clinician. It is one of the most important key performance indicators in our clinical labs, as it evaluates quality management, reflecting both on efficiency and customer satisfaction. If our turnaround time is good, customer satisfaction is good. If our turnaround time is good, it means it goes ahead to speak about our efficiency as a lab in sense. So we transition to a redefined definition to have a better understanding and to cover more processes as such. Under redefined definition, we look at turnaround time as the total time lapsed from the moment a patient initiates a laboratory testing process to the point when the test results are acted upon in clinical making decision. Total elapsed time from the moment a patient initiates a laboratory testing process to the point when the test results are actually acted upon in clinical decision making. So this actually refers to the measured time from when a patient presents for a laboratory test to when the test results are verified, released, and used to inform clinical management decisions. You see that this refined definition goes beyond the testing process, because it's measuring the time from when a test requisition is made to the time when a verified result is actually used to make a clinical decision for a patient or a client as such. So this definition, it goes beyond the traditional sample received to result release view. Because when we were talking about generic definition, we say generic definition is about the time that has lapsed between sample receipt and result review or result release to the patient or the clinician. But this one goes beyond that definition to actually encompass all the stages that influence timeliness, relevance, and clinical impact of the laboratory results. Okay, it goes beyond pre-analytical and analytical phase. It goes to an extent what we call the post-analytical phase of TAT evaluation. So why is this redefinition important? Why this redefinition matters? We look at the refined definition actually gives a holistic view of service efficiency in the sense that it captures every step in the diagnostic journey, be it administrative, be it technical processes, be it clinical. And hence, it ensures accountability across all teams: reception, phlebotomy, testing, reporting, and clinical staff. It gives a holistic view of the service efficiency of the entire testing process, from the time the patient walks into your lab to the time when that result is actually used to make a clinical decision for that patient. Number two, it also looks at it gives an improved patient-centered care. It has gone beyond you just releasing that result. It actually covers the period upon which that result is actually used to give a clinical decision for that client. So the ultimate measure of timely laboratory performance is how quickly the result leads to clinical benefit, not merely how fast it's produced. It does not just stop at how fast you produce that result. It translates or actually goes to up to the point where you ask yourself, how quickly has this result actually reached the clinician, and how quickly has it been used to inform a clinical decision when it comes to patient management. Of course, number three, it gives an enhanced quality metrics. It gives an enhancement quality metrics in the sense that redefining TAT allows laboratories to identify bottlenecks at each phase, support root cause analysis, and guide continual improvement. When we will be discussing these phases of TAT, we will be looking at this phase, what could be the problem, what can cause delays, and what can we actually do to make sure that we have improved those processes to make sure that we conform to your turnaround time. And colleagues' turnaround time must be established and effectively shared to the clients as such. And it goes without saying that true TAT is not just how fast results are produced, but it's how fast they improve patient outcome. It's not all about the speed of production of results. It's how fast those results that you have produced can actually inform a clinical decision on the other hand of on the other side of management, patient management. That is why when we talk in terms of ISO 15189, it emphasizes that every result must be delivered within the acceptable time limits, and it should actually be used to make a clinical judgment for that patient. What role do you as a lab actually play when it comes to clinical patient management as such? So let us then dive in discussion of phases of turnaround time. Because holistically, we have said that turnaround time actually is the time when the patient walks or the patient seeks your service, your lab service, and to the time that patient result is actually verified and released and is used to make a clinical judgment for that patient. So in between the client walking into your facility and that result being used to make a clinical judgment, there are a few phases that we need to discuss so that we better understand what TAT actually means. Because TAT is not a whole package of it. It's actually broken down into systematic aspects that we need to discuss as a lab. So TAT should not be viewed as a single duration, but as a series of linked intervals from patient arrival to result authorization. That is something that I've just previously pointed out. So we need to actually break it down into measurable components, which allows more precise performance monitoring and process improvement. Okay. So these are actually the phases of turnaround time that we are going to have a discussion probably in the next 40 or so minutes. So we have a duration that covers patient arrival to your facility to patient registration. When a patient arrives in your facility, when a patient arrives in your lab, and this is accurately captured by those standalone labs. But for labs that are actually in hospital, you are looking at it by the time the client visits a clinical room and a requisition is made. How easy is it to collaborate between the clinical room and the lab to get that? So the time when the patient arrives in your lab, if you are a standalone lab, to the time of registration, time of arrival to the time of registration. Registration here means the time you register this or you put this patient details or you start a visit for this patient in your system. Okay, so this is actually the time interval between when a patient walks into the facility and when they are registered in the laboratory or the hospital information system. And I'm repeating for emphasis that this is better looked at when you are assessing from a point of a standalone lab for lab aspects. Because if you look at it, it's living from the time the patient arrives and probably sits in your waiting bay. How long do you take to register that patient for the service? That is basically what this concept is about, okay? So what is the goal? The goal is always to register these clients as soon as possible. But how soon? You must have a performance goal. So generally, within established, and the examples that I'll be giving here are within established healthcare systems, okay? Generally, it should be within 5 to 10 minutes for walk-in or outpatient clients. When a client walks into your lab, standardized time for systems that are working well, it should not go beyond 10 minutes for you to register that lab, that client in your system, okay? So how then do we monitor this? How then do we monitor to ensure that actually we are conforming to the performance goal? We are actually continuously reviewing ourselves to see how better we can be. How do we monitor this? Compare the actual times versus the targets. You as a lab, you as a healthcare facility, you have come up, and this is something that you need to do in consultation with all the relevant departments. You have come up, your quality improvement team has come up with a target TAT of 20 minutes, for example. You have set 20 minutes saying that when a client walks into our facility, when a client walks into our lab, it will not take more than 20 minutes for this client to be registered in our system, okay? So you have 20 minutes as your target TAT when it comes to registration time, okay? So evaluate what you are achieving against your targets. Then see where deviations are. Once we have deviations, then we come with appropriate corrective actions as a way of improving service delivery, because we must always have a way in which we improve these services at all costs. So we say that identify causes, e.g. understaffing, system downtime, and queue congestion. These are causes that might actually make TAT around these areas to be overly prolonged. And it's our responsibility to make sure that what those causes of prolonged TAT are, and we sort them out with corrective preventive and corrective actions that we put in place. So what is the significance of actually evaluating this duration, the time when a patient walks in and the time of registration? What significance does it bring? Of course, it represents front office efficiency and client handling, okay? When clients are being registered promptly and the registration is following laid down rules and regulations, it means the front office efficiency and client handling is well, okay? It goes ahead to reflect how quickly the client's request is initiated and entered into the system. Of course, through evaluation, we see process improvement. How quickly can a client request be initiated and how quickly can it be registered into the system? It is a very good parameter that we can actually focus on when it comes to that. Of course, delays in this aspect may actually indicate bottlenecks in reception of front office performance. It might also reflect bottlenecks in terms of payment, how cost effective your services are, and it also reflects bottlenecks in terms of patient identification, because proper registration, proper full registration has to have all accompanying components as required by the data protection and aspects of such. So number two, we look at the second phase, whereby we are evaluating registration to sample collection time. By the time you put that client into your system, that yes, I've entered your details in our laboratory information system, you have requested for a typhoid test, okay? Your details have been captured effectively. So how long does it take when a patient has been registered to the time we actually collect samples from this patient? It's a very good metrics for us to measure, actually. So it's actually reflects on the time taken from the patient registration, when the patient request is logged, to the actual specimen collection. For example, we have an inpatient client in our ward. A clinician orders a request in the inpatient request. How long does it take for a logged request in inpatient to reach the lab and that request to actually transform to patient sample collection? There's no permanent aspects on how you look at this, because the examples I'm going to give as performance goals, these are examples, they work so well for outpatient facilities. But for inpatient facilities, you must then come up with your own established turnaround times, targets that you have set in consultation with the clinical teams, in consultation with the nursing services, so that you agree that yes, when an inpatient request is logged, it will take 1 hour for that patient to, for that sample to be collected. Okay, so in most cases, we get blamed because we do not have established and shared or agreed upon timelines that we have set that we will operate within. So this is actually the time taken from patient registration when the request is logged to actual specimen collection. So what is the performance goal? Performance goal. And I've said examples that I'm giving, these are for well-established systems and for outpatient aspects only. But for inpatient facilities, you therefore have to sit down with the clinical teams to come up with the most appropriate times that do not infringe on the patient care as such. So the performance goal for this is for routine outpatient samples. Routine outpatient samples, we are saying that you should not take more than 15 minutes after registration for sample collection, okay? But we also go ahead and tell you that for start or urgent tests, sample collection should actually be immediately or within 5 minutes. When we talk of start tests, we are talking of tests that actually need immediate intervention, immediate tests, high priority tests, okay? These are life-threatening tests that we need results immediately. Okay, in examples of blood gases, these are aspects that we need to look at. For urgent tests, start tests and urgent tests, this has to be immediate. There needs to be immediate sample collection, or at most within the very first 5 minutes of sample requisition as such. So what is the significance of looking at this time? Why do we need to look at this time? It actually reflects on the efficiency of sample collection workflow and patient flow within phlebotomy or sample reception areas. Okay? Efficiency of sample collection workflow. How efficient is your sample collection workflow? How controlled is your patient flow in and out of phlebotomy? And how controlled is your patient flow in and out of your reception area, because that is where they sit and await for service delivery as such. So when we have prolonged or long intervals beyond your target values, when you have long intervals beyond your target values, of course, this will actually, they always arise from delays in number one, patient movement between reception and collection, especially those patients who need support from one point to another. Do you need to transfer this patient from your reception area to your phlebotomy area for sample collection, specimen collection, and they need some assistant intervention? Of course, it takes that time and it might delay the collection of sample. Of course, we are saying that we have, during surge periods, maybe you have waiting queues at the phlebotomy. That is something that needs to be put in consideration, and you look at it. Of course, sometimes it's personnel related. The phlebotomist is not available, or they are taking so long to prepare just to take a sample. Of course, we always emphasize that sample collection preparation is very key, but do not also overstay on collection until you lose the focus as to why you are actually doing those processes as such. Okay. So how then do we improve? What are the improvement measures that we can put in place to make sure that the time between sample registration, patient registration, and sample collection is timely? Improvement measures can be looked at in this way. One, use queue management systems of phlebotomy schedules to manage our work. We can also align staffing levels with patient load. Whenever there's a patient surge, we must also provide a correlating number of staffs to make sure that sample collection is as timely as it can be. We also ensure that request forms and barcodes are ready before collection. Just making sure that whatever we need for any sample collection processes is readily available in our phlebotomy room, so that we do not waste much time going to look for those services or those consumables before we attend to our clients. So before beginning of any shift, you make sure that whatever that you need, be it Vacutainer tube, be it whatever, any sample collection are actually available, readily available in our phlebotomy rooms, so that we reduce on that time we take to do that. Then the third aspect that we are looking at is just something to mention on those two aspects, A and B, that I've mentioned. That is actually what constitutes what we call pre-analytical TAT. Okay, pre-analytical TAT. Pre-analytical TAT actually comes to the point until when the sample has been collected and it has been submitted or receipted in the lab. So the very first two aspects actually conform or form what we call the pre-analytical TAT. Then we look at sample receipt to result authorization time. Sample receipt, the time when you receive your sample in the lab or is receipted in the performing bench, to the time when an authorized result is actually released. And that is what we always fondly refer to as analytical turnaround time. So this is actually the time from when a sample is received in the testing section to when the final result is actually verified and authorized by the technologist or pathologist. Of course, we always emphasize that results must be verified before release by staff who are actually being deemed competent enough to check for that. So what is actually the significance of looking at the analytical turnaround time? What is the significance of looking at the duration between sample receipt to result authorization time? This actually represents the core analytical TAT, which reflects technical efficiency, instrument performance, and result validation speed. How good is your technical efficiency systems that you are put in place? How good is your quality management system? How good is your instrument in terms of performance output? How good is it? Do we have system downtime? Do we have maintenance issues? And how fast do we actually validate our results as such? Of course, we look at what are the major influencers in terms of what actually majorly influences this process is aspects with reference to equipment uptime and maintenance. If your equipment is well maintained and is stable, it means it's performing optimally. The analytical turnaround time will be okay. If your staffs are competent enough to undertake those processes and your workload distribution is good, it means analytical turnaround time will actually be good. We also look at if you do not have any QC issues, your reagents are available, you do not have stockouts, your LIS is stable, your laboratory information system is stable, it's functioning optimally. We do not then intend to actually have these issues. Of course, there are so many parameters that actually contribute to either achieved or unachieved analytical turnaround time, which what I've just mentioned are a few components that you can build up on that to actually help understand this aspect better. And it's actually the core business of our existence, to make sure that, yes, we have a quality, reliable, precise, and timely result to our patients. So what are the improvement measures that we can put in place to make sure that our analytical TAT is actually controlled? Okay. We look at implement real-time TAT tracking via laboratory information system. For those of us who have actually been blessed enough to have systems, operational systems in terms of laboratory information system in place, we can actually track our analytical TAT. The time when you received that sample in our analytical bench, be it chemistry, be it hematology, when you receive that sample, how long does it take for you to produce a result and that result to be validated and released to the patient? That is the core business of our existence. So of course, once you have tracked your performance, when you identify outlier reports, have a discussion about these outliers. Why do we have these outliers? And outliers in this sense, we are saying some turnaround times that have actually gone far beyond the expected TAT. You see, if actually your TAT is 1 hour, but you're producing results at 3 hours, it tells there's a system issue. There are systematic issues that you need to look at. But it also looks at if your turnaround time is actually 1 hour and you are giving results within 10 minutes or so, it also begs questions. Is either you are not conforming to our quality management systems as you have declared as such, or you over-declared your turnaround time. So these are measures that we actually need to look at to make sure that we do not give room for subjectivity. Of course, once we have identified these outliers, we conduct what we call root cause analysis for delayed results. Yes, we have delayed results. We have extended TAT. Did you first communicate to the clinical team that, yes, we will have an extended TAT? No. Did you explain to a client at your outpatient facility and tell them, yes, we usually produce these results within 1 hour, but due to this and this and this, we will produce these results within 2 hours? Did you communicate? If there's no communication, then it means something is amiss somewhere. And of course, we then go further and see why are we producing results beyond the declared TAT. So once you get the root cause as such, you come up with effective corrective and preventive measures as such. Then we always emphasize, for a system to be effective, maintain adequate reagent stocks and equipment uptime. Make sure that your equipment are well maintained, your equipments are performing optimally, so that and the reagents and consumables are actually available for processes to proceed as it's expected. So we are saying that we looked at the time from arrival to registration, then we looked at registration to sample collection, and we have looked at sample collection to release of verified result. So this concept that is actually displayed on your receipt, on your screen, actually looks at integration and total laboratory TAT. It's just an emphasis that yes, these processes must be effectively integrated together. They must work seamlessly, okay? So when the previous three aspects are actually combined, these segments represent what we call the total laboratory TAT, from patient arrival to result delivery, okay? So total TAT, just what I've said there, is equals to arrival to registration time plus registration to collection plus receipt to authorization time, the time in between there, of course. So monitoring all these three intervals provide a comprehensive view of patient's journey. How is the patient actually transitioning from one phase of management to another? It also provides a data to identify which phase contributes the most of the delays. Which phase actually contributes most of the delays when it comes to this. And also it serves as evidence for corrective and preventive actions under ISO 15189. So actually, when we look at this integration and total laboratory TAT as displayed on your screen, that actually gives you what we call the generic definition of turnaround time. So there are two more sections that we are going to have a discussion about. So those two more aspects are actually what bring in what we call the refined definition of TAT. So this is one of the sections. We are looking at the time of results uphold to verification. Very important subject that most of us usually ignore, but it actually tells us how well our systems are performing, especially for results where when one staff actually performs, it must be verified by senior technologists in that lab or senior pathologist before that report is actually released. It's called the time of result uphold to verification, result hold to verification interval. This actually refers to the time duration between completion of analytical testing, that is when the instrument generates results, and the final verification or authorization of those results by qualified laboratory professionals, and those are technologists, section heads, or pathologists. If there is a policy in your lab that results, all outgoing results must be verified by your senior technologists, by section heads or pathologists, it means this aspect always comes in. We never miss it, okay? So you as a technologist, you have performed your test analysis on the analyzer. You have done your UECs, you have done your LFTs on the analyzer. You have either interfaced it to your laboratory information system, or you have entered it manually to your laboratory information system. Does your system allow that result to be complete? Or does it actually, now that you have put result, indicate that you must have to wait for somebody else to come and verify that result? Do you verify your own work? If you do not verify your own work, it means there's a competent or a senior staff who will come to verify that work. And if there's that staff who come to verify that, or there's this time lapse between when you uploaded the results in your LIS to the time when this person who is been empowered to verify your results will come to verify. How well do we then manage that transition? That begs the most important question. Okay, so result uphold to verification time, this is equal to time of result availability on instrument or LIS to the time of result authorization in the LIS, because you can only print verified authorized results in the laboratory information system. So if that is the case, there is a lag phase that we need to have a discussion about. So what is the purpose and actually the significance of looking at these areas? This time interval evaluates post-analytical efficiency and data integrity assurance processes within the lab. Of course, we are looking at, we want a second alternative technology to come and actually review our work and authorize it, or a pathologist as such, because it's one of a data integrity assurance process. But then we also need to look at the processes. How efficient are those processes? It's not all about authorization. You know, you can upload a result in the lab in the evening at 7 p.m. and go home. You come back in the morning, you will find the very same result has not been verified, has not been authorized for output. So you produce your result timely, but authorization or verification has taken an extended period of time, even beyond the analytical phase of that. So that is something that we need to look at. So we look at it, even if analytical testing is completed on time, delays in result review and verification can significantly extend the total turnaround time, affecting clinician satisfaction and patient care decisions. Yes, you produce your results, you complied with the SOPs, you complied with the quality management systems in regards to production of that result, but you have produced the result, but there is somebody else who needs to come and verify that report before it's ready. But this person actually delays, okay? So you did everything. You conformed to recommendation as such, but somebody delayed to verify that result. So it actually translates to delayed patient management, okay? So that is something that we need to look at. So key reasons this interval actually matters. One, in terms of clinical relevance, delayed result release may postpone diagnosis or treatment for a patient. I've just given an example. If you release, you actually interface your results at 7 p.m. and somebody comes at 10 p.m. at night to verify those results, that is delayed. 4-hour difference. Of course, that is something that we look at. In terms of quality assurance processes, verification actually ensures that results are technically valid and clinically appropriate. But then, even if we focus so much on quality assurance in terms of verification, it must be, yes, a quality result, but it must be on time, okay? In terms of data integrity, it provides traceability, accountability, and compliance with ISO 15189, clause 7, 12, 13, review and authorization of results. Of course, there is compliance, but how is this compliance actually translating to patient management? That is something that is very key and important to look at. Of course, operational insight, it helps identify staff, shift or system delays in post-analytical phase. Okay, reviewing this process can actually tell us, is there a problem of authorization staff deficiency? Is there a problem of are shifts turnover actually leading or directly implicating on performance of the analytical phase? So those are things that we need to actually focus on and see. So common causes of delays when it comes to this aspect is, number one, you might find staff-related issues whereby you find there's a pending review of a result due to workload. The staff who is actually supposed to review those results is busy with competing responsibilities. Workload imekuwa mingi, they are focused on other things, okay? Or it's after hours backlog. You are looking at, yes, somebody needs to authorize or to review that result, but it's away. Or it's he has completed his shift and he has gone home, okay? You need to wait for that stuff to come tomorrow, okay? Or there was just incomplete handover. You just did your test, you put it in the system, you did not notify me as a person who is actually supposed to authorize that report, and you went home. So when we identify these common causes, we do what we call a risk assessment. Once you have identified these causes, you do what we call a risk assessment. You look at these processes and put in place effective mitigation plan. If it's an issue of workload, how then do we circumvent this workload to make sure that our reports are actually being verified on time? How then do we circumvent this issue of after hours workload? Or how then do we circumvent this issue of incomplete handovers? When we look, we identify the problem, we come up with appropriate measures in which we put in place to assist that. Of course, it could also be system related. We look at it that laboratory information system instrument interface issues. Yes, you have completed your test on the analyzer, but you cannot interface your results because we have a corresponding issue on either side, and it does not allow you to feed results manually because we have those systems that are blocked. Or we have a slow data upload or network interruptions. These are systematic system-based issues that can actually be looked at. And once we look at these issues and we identify, we do what we call appropriate risk assessment, and we come up with a mitigation plan to help us actually control the risk as such. It could also be quality related, whereby we have QC or data checks flags require result validation before release. We are looking at, yes, you have uploaded your results, but then you need to do QC checks before you release that result. You need to do some data checks, flags requiring that, yes, this result, you have produced it, but it has to be validated before it's released. Or it could also be administrative related. You are also waiting for your supervisor or pathologist authorization or secondary review before that result is actually given out. And this very last one is actually what hits us the most. You are waiting for your supervisor or pathologist authorization or secondary review to actually have that result review. Once we identify that this is an aspect, we put it in terms of risk on our risk. As a risk, we look at effective mitigation plan for our risk. And we also look at effective evaluation to see whether the mechanisms we have put in place are actually functional or not. So how do we monitor and control these aspects? We look at, number one, track verification delays in your laboratory information systems. Of course, we are trying, how do you do that? You compare result availability time versus authorization time daily, okay? How long is it taking for a result to be available on the LIS and to be authorized for release? Those are times that we can actually be used to verify this. Of course, this actually helps in identifying or flagging outliers for review. Once you identify outliers, you then design what we call CAPA, corrective action, preventive action. But first, you have to identify the root cause of that. Then once you have that, establish escalation protocols. What do you do when your supervisor or pathologist is not around to review that report and the report is actually needed? Okay? Or what mechanisms have you put in place to ensure that, yes, whoever is supposed to authorize reports actually get timely notifications to authorize those reports? So we look at in terms of automatically notify section leads for delayed pending results beyond threshold. Those are things that we need to look at as service provider to make sure that our services are top-notch as such. Of course, we look at implementing shift-based accountability, assign responsibilities for final verification per shift to ensure timely review. That is something subjective enough that we can put in place to make sure that our shift handovers, or per shift we have somebody actually available to verify and release those results on a timely basis as such. Of course, we talk of just to enhance, to look at it in terms of enhancing process improvement. We look at it as integrate with CAPA system. And when we talk of CAPA system, this is just a fancy word of actually referring to corrective action, preventive action. We are saying investigate recurrent post-analytical delays and document corrective actions. Whenever we have recurrent post-analytical delays, kindly do a trend analysis. Find out what is this that is hitting us much, and what actions can we actually put in place to make sure that we have an active control over the system as such. Then finally, we look at it in terms of continuous improvement. Always analyze patterns to improve staffing, to improve connectivity, to improve QC verification workflows. I've said, whenever we have recurrent post-analytical delays, do what we call trend analysis. And when you do trend analysis is when you are trying to analyze identified patterns to see what is this that is hitting us the most. Once you identify that, if it's staffing issues, work on staffing issues. If it's connectivity issues, work on connectivity issues once and for all. If it's QC verification workflows, kindly work on that and put it in place and make sure that it sticks as such. Then we have this time between result receipt by the patient to clinical management. This is actually where most of us, it hits us the most. We are looking at, in most cases, we have been accustomed to our TAT ending by the time you release that result to either patient and the clinician. No, it does not end there. Under ISO 15189, it tells you that, yes, that result must actually transform to a clinical decision. That is where and when your TAT will end at. So we are looking at, this is the interval between the moment a laboratory result is received or accessed by the clinician. Received, that is received in the sense that if you are handing over paper, hard copies to the clinician, or accessed if in the case you are using your laboratory information system by the clinician or patient, and the initiation of an appropriate clinical action or management decision based on that result. Do we ever look at that? That yes, I've produced a very nice report, a report that actually represents the patient condition. But then do we go ahead and look at the time when you have given that patient your result to the time when that result will actually be used by the clinician to actually make a clinical judgment at the other end? Something very important that we fail to look at. So clinical action time we look at is equal to the time of result receipt, the time of clinical intervention. Okay, a result is only good when it actually translates to a clinical decision. This, of course, for all of us who have come across this term, sometimes is referred to post-analytical phase. We are just looking at the impact of your result to patient management. The stage where the laboratory data are actually interpreted and applied in patient care. So what is the purpose and the significance of actually looking at this phase? This time interval reflects how effectively laboratory results are actually communicated, interpreted, and acted upon in healthcare system. Okay, it's not about dishing out those reports. It's not how fast you gave out that report. It's how fast that report has actually reached the clinician table and it has actually been used to inform a clinical decision. Okay, looks at how are the results communicated, how are the results interpreted, and how are the results actually acted upon to make a clinical judgment. So we look at it in terms of even the most accurate results, you have really complied with your QMS system and you are fully satisfied that yes, whatever I've given out is the best. Okay. Even the most accurate result holds no clinical value until it informs a medical decision. If that result that you have does not translate into a medical decision, or is not timely used to inform a medical decision, it makes that it did not serve the purpose. And this is where now, this is the point where we always have war with our clinical team. Where you as a lab tech, especially in inpatient facilities, you give out results, it's waiting for ward rounds. The following day, you give a result at 3 p.m. today, it's waiting for ward rounds at 1 p.m. tomorrow for it to be used to make. You see, that is, and when they get that result again, it becomes a problem, because the very first thing they'll always say is that we received the report late. Okay, so how often do we as lab techs actually follow up to make sure that, yes, it's not about submitting the report, but I've submitted this report, and the person who is intended to have this report has actually received this report, and the report has actually been interpreted in the context that can help a patient. That is a gray area that we need to actually look at. In terms of significance, clinical impact, it looks at timely interpretation ensures faster diagnosis, initiation of treatment, and improved patient outcomes. Of course, when a result is timely interpreted, it means that whatever that was being inferred to can actually be timely identified and corrected. In terms of patient safety, it reduces risk of delayed or missed clinical interventions, especially for critical or life-threatening conditions. Okay, communication efficiency, also this aspect actually evaluates communication efficiency, evaluates the responsiveness of clinician laboratory communication channels. Did you just release the result in the LIS and keep quiet? Okay, that is something that we need to look at. We must always follow up to see the end product that comes from our result. Of course, quality integration demonstrates how laboratory performance influences the overall healthcare delivery system. And in terms of this, especially for referral labs, this is where it hits us the most for referral labs. So we must always make sure that, yes, it's not about just loading the result on a patient email. Do we even make a follow-up phone call to see if that patient can actually access that email that you have sent the result on? What is the clinical impact of this result that we have shared with this patient? And as always, for referral facilities, turnaround time is always as per the SLA, service level agreement. So when you are negotiating with us or with somebody else, we must always discuss issues around turnaround time. We agree on what works for both of us. And in case there are deviations, of course, we are not saying this is a system that is built or it's cast on stone. Turnaround time, we might have deviations, but when we have deviations must be communicated with corrective actions and preventive actions that have been put in place. So common causes of delays in this aspect we refer to, of course, we might have them categorized as communication barriers, delay in notifying clinicians of results, or poor LIS, HIS integration. Yes, there's a poor integration between your hospital system and your lab system and the general hospital system, so that once you have posted the result, the clinician cannot even see the results on time. We have a lag phase of like an hour for results to actually show up on the clinician test. That's something that we need to look at. Of course, workflow gaps. Maybe you release the results, but the clinicians are not available, or results not reviewed promptly. Okay, that is something that we need to, yes, you send the results. The clinician was not available, so they did not review those results on time. So that is a gap. It could be patient-related factors that actually affect this. Of course, delay in returning to facility. Yes, maybe the patient went to seek services elsewhere. After testing, anapewa majibu na anarudi na majibu nyumbani, anakaa nayo. After 5 days, 4 days, when they are still looking for fair, is when now they realize, oh, I need to go back. So that actually contributes to this. Of course, there could be an issue of an awareness of result availability. Yes, this is, I pointed out that, yes, you have a patient said that send me results on my email. You have sent results on his or her email, but you haven't notified them through telephone engagement that we have sent results. Of course, that actually raises this concern as such. It could be a system factor. Of course, lack of automated alerts. If you do not alert me that the result has come in, I might actually miss that report as such, especially for critical results. A result that needs to be acted on at that time, we need to have automated systems that actually report on that. Of course, manual report delivery in the event that, yes, I'm bringing a manual report delivery to the doctor, but I get there, they're not there, or aliweka hapo hata akasahau kuita mgonjwa mwenyewe. So those are some of the things that we actually look at to make sure that our systems are performing well. Of course, performance goals in regard to post-analytical TAT, there is no universal time limit, since this interval depends on test credibility and clinical context. How critical are your results? If these are very critical results, then it has to be acted upon immediately. And also we factor in clinical context. But we always insist that you as a lab, you should always collaborate with clinicians to define reasonable targets when it comes to post-analytical TAT monitoring as such. So how do we then monitor and improve post-analytical TAT? We must put in place systems that can enable us to get notifications in terms of critical results. Of course, clearly stated, we must critical results notification policy, we must have a policy in place that enables us to notify, or even the clinicians to themselves get notified when we have critical results as such. Of course, we also need to look at strengthening laboratory and clinician communication. Use integrated LIS, HIS systems, secure messaging, or automated alerts. Ensure receipt confirmation, electronic or verbal, as such. Of course, education and awareness, we must train clinicians and nursing staff on interpreting and acting on results promptly, okay? Colleagues have always ensured that you must interpret what you're producing. That is an ISO recommendation. You must actually aid in interpretation of what you're producing, okay? We must also do an audit of our system and feedback, whereby we regularly audit critical result turnaround time from release to action. And of course, through this, we also discuss delays during clinical laboratory interface meetings and management reviews as such. Just a question that how often do you then have your clinical laboratory interface meetings? How often do you usually have this, if you have them? And how often do you then have management review meetings within your meeting? And what do you discuss? Are these part of the aspects that you discuss as such? Of course, patient engagement. For direct-to-patient results, those are results that you are giving to the patient for the patient to return to the clinician. Provide counseling and ensure that they understand when and how to seek clinical follow-up. Okay, that is very relevant and very important for our case as such. So, colleagues, with patient engagement, that forms our final slide for this presentation. But as always, I have a parting shot for you. And this is how it goes. Turnaround time is not merely a numerical measure of how fast a laboratory delivers results. It is a composite reflection of quality, efficiency, teamwork, and patient-centered service delivery. A laboratory's true excellence is demonstrated not only by analytical precision, but also by how promptly and seamlessly results are translated into clinical decisions that improve patient outcomes. By understanding and managing each segment of TAT, from patient arrival, registration, sample collection, and analysis, to result verification and clinical management, laboratories move from reactive problem solving to proactive performance optimization. A well-managed TAT fosters, number one, operational efficiency by identifying bottlenecks and improving workflow coordination. Clinical relevance by ensuring that results are available when needed for patient care. Quality assurance by linking technical competence with service reliability. Client satisfaction through timely, consistent, and dependable communication. Ultimately, turnaround time is a bridge between laboratory data and clinical action. When every stakeholder, from reception to the testing bench to the clinician, understands and owns their role in that timeline, the laboratory fulfills its mission. And the mission is delivering accurate, timely, and impactful results that advance patient safety and quality healthcare. Every minute saved in the lab is a moment gained in patient care. And that is the true essence of quality. Thank you very much, Nelly. I bring it back to you.
Thank you. Thank you very much, Davis. We can give him a clap, his flowers, and all the happy signs. Thank you. Thank you so much for the presentation. Quite clear and quite elaborative, insightful, and we've really learned. Thank you so much. Yeah, thank you. Receive the flowers and the clap and all the signs that people are happy and people have been taught there, Davis. And thank you, members, for being here, for staying throughout the time and for learning. I'm just scrolling through the comment section and it is all busy with people appreciating you, Davis, for the clear presentation, for the elaborative, and people have really learned. But there's one question. There's a question from Ezekiel Chumba that maybe you will want to react to that. As I'm still here waiting for more questions. If you have a question or a contribution, kindly put it up on the chat section. So Davis Ezekiel Chumba says, on the issue of phone call follow-up, some facilities do not have airtime for calls. Can we then push to have call allowances?
Thank you very much for that question. It's those are some of the questions that we usually expect once we have a presentation of this nature. This is a justification for you to use to actually get that phone call allowance that you are looking for, in short, because at the end of the day, the question that will be raised is, why do you need this allowance for? Okay. Yes, the question is, we need to make follow-ups. And how do we make that? We are doing phone call follow-ups. And for you to do a phone call follow-up, you must have credit. So depending with where you work, I know some of us, we are facilitated with that. So depending with where you work, you must actually also use this as a justification for you to get what you need. But it's essential that you get that phone call allowance for you to make that call. Or we have settings whereby facilities are actually provided with a facility phone, mobile phones, so that you can actually use a facility mobile phone, because I believe it always has credit. So regardless, whatever works for you, either the other side you're on when you get a phone call allowance, or you use the facility phone to actually make such communication, whatever works. Thank you.
Thank you. Thank you, Davis. Members, I will also urge you to click the link that is on the chat section on the WhatsApp group for LMSK CPD WhatsApp group, kindly, because I'm seeing questions here from Sebelina Kawira and Dan Odhiambo concerning CPD. Kindly just join the WhatsApp group, and more details concerning CPD and how to check your CPD, how to confirm that you've been allocated your CPD will be answered and will be shared. Kindly join the WhatsApp group, the LMSK CPD WhatsApp group. Thank you. Thank you so much, Davis. It was clear. It was elaborate, and the reason we don't have many questions. Members are satisfied. Members have gotten educated and gotten the concept on understanding turnaround time in clinical laboratories. So we'll take this opportunity to appreciate you for preparation and for being here to present to us. And thank you so much, each one of us, for being here this evening. We really appreciate, and we're looking forward to seeing you again on Wednesday and on Friday for these elaborate and educative presentations by our own members in these LMSK webinars. Thank you so much, LMSK, also for organizing this and for making sure that all systems run, that we are here to learn and to really educate ourselves on issues pertaining to our profession. Members, have a good evening. We're looking forward to seeing you on Wednesday.